Well, thank you, Lucinda. It really is a distinct pleasure for me to introduce Sam Thayer. It's common to say when you're introducing somebody like Sam that he needs no introduction, and indeed he doesn't. So I'm going to be very brief. I'm going to only take me about 30 minutes to do the highlights of his career. So it turns out that Sam and I have known each other and been friends for about 50 years. We met as renal fellows together, not in the same institution, but in the same city, and I've known Sam since that time. Sam was born in Brooklyn, went to the very famous James Madison High School, matriculated at Cornell when he was 16, only spent 3 years there because there wasn't more he could learn there, so he went on to medical school at Syracuse at that time, finished at Syracuse and became the first graduate of that medical school to become an intern at the Mass General Hospital, where he has obviously spent a great deal of his career. But as a resident and as a renal fellow at the General, he met Bud Relman, who shortly after that became chairman of medicine at Penn, and he recruited Sam shortly after his chief residency to become associate chairman of medicine at Penn, where he established a stellar reputation as a leader, as an educator, as a clinician, as a researcher, and it really started his meteoric rise. From Yale, he was tapped to become chairman of medicine at Penn. He was tapped to become chairman of medicine at Yale at the tender age of 37, where he served with distinction until he became his first presidency. He became president of the IOM, where he served for 6 years in this venerable institution. Following that, he was tapped to be president of Brandeis University, where he served for 3 years, I think. And then, if that weren't enough presidencies, he became president of the Mass General Hospital shortly after, just about the same time that the Mass General and the Brigham became together as Partners Healthcare, and Sam was the president of Partners Healthcare and the CEO of that, a very important organization, one of the first of the wave of collaborating institutions that I think was a forerunner of what we're now commonly called accountable care organizations. Well, Sam served in that role with extraordinary distinction, obviously taking those institutions, both of which Brigham and the General had been around for about 300 years apiece, and managed to meld those cultures in ways that I don't think anybody thought was possible. But in any event, Sam did that, stepped down from that critically important leadership role in 2002, and since that time has been retired. Retired, meaning that he's only had, I'll mention a few of the things he's done since his retirement. He's been on the Board of Trustees of Cornell University, of Johns Hopkins University, of one other thing I've forgotten here, of the Yale New Haven Hospital. He also was the chairman of the board of the Commonwealth Fund, and has also continued to be active as a clinician and a teacher. He tells me he was making rounds at the General until just this past year, and is still taking morning report at the General. So this is a man of extraordinary distinction, and I can't wait to hear what he has to say. Sam?
How do you? What service? When I was at the IOM, we didn't have that. It's a pleasure to be back here. And Jordy, thank you very, very much. I'm going to try and do a few things in this introductory remark. First, I'm going to see whether I can tell you what I ran into. I had my assistant type this up, and she said to me, "What's interprofessional education?" I said, "I don't know for sure, but I'll probably know it when I see it." And she said, "Oh." I said, "But I'm going to a meeting. And when I'm finished at that meeting, and I've heard the discussions, I will be able to give you a lot more precise definition." What I'm going to do today is kind of challenge you a little bit to help clarify for me what interprofessional education actually is. I'm going to go through, just writing it down for me created chills some of the challenges I had in trying to put together interdisciplinary groups or interprofessional groups, and some of the lessons to be learned from that. And then at the end of that, just add one or two questions which I hope will allow you to keep me educated. Given the U.S. healthcare system is fragmented and expensive, but can and should be reorganized to improve access, quality, and cost. Even in the countries with excellent access to care, quality and efficiency can be improved. Now, if we can't take these as given, I don't have anything else to say. I do think that this has to be an accepted starting point. I do not have on here as a given what happens in sites and organizations and countries where the complexity of the politics or the complexity of the resources makes it very hard to say that one could certainly improve efficiency and quality. Nonetheless, I want to keep in the back of our minds the fact that there is a vast opportunity and responsibility out there to, in fact, address those issues, and to address those issues in ways which can be designed and looked at on one at a time, instead of looking at what might be a national kind of approach. Even if you wanted to have a national type of approach, that will turn out to be a lot more complicated than one might think. So I think if you want to take the given, I'm going to put forward a set of assumptions here, which I hope will lead into what we're talking about in terms of interprofessional education. I think the assumption is that we have the knowledge, competencies, and resources to improve the outcomes and experiences of patients, families, providers, and funders. That's quite a list, because they don't all have the same expectation, and they can't all be satisfied in the same way and at the same time. And therefore, that assumption is fraught with a lot of potential for going awry. Nonetheless, I think we should be thinking that that is something that we would like to see we'd like to be able to do. And if we are able to do that, one way to do that would be through interprofessional education. Not the only way, but certainly one way. We can tailor care to match resources. This is a critical issue, particularly in less developed countries which don't have the resources. But I think it's important to recognize that that is also an issue in places like the United States. So let's just take an example. If you were to wish to set up a healthcare system which served the same efficiency and quality in New England as in Alaska, what would you be facing? If you are in New England, there are 10 medical schools. You can't be more than 50 miles from a tertiary care facility. People are tripping over each other to provide some educational activity. Now, look at what happens in Alaska. Many of you may not know there is an organization called WWAMI. Used to be Washington, Alaska, Montana, and Idaho. Now we've added Wyoming to that. That hasn't helped in terms of the population. That's an area which is an enormously broad area. And I love the University of Washington started out trying to get this going. And one of the things they did was say, how do you deal with this? What does a rural healthcare system have to deal with? What is rural? And this being the United States, they went to the marketing people, and they said rural is more than 200 miles from the nearest McDonald's. They're very good marketers, and if you're more than 200 miles away, you are really rural. Okay, so now look at what happens there. You have these small hospitals, and these small hospitals scattered around turn out to be critical to the culture and to the survival of entire population groups. And if you go to those groups, you will find out that there are three things that determine what works. One, you have to have with the hospital, a nurse, a doctor, and a pharmacist. If you have those three professions, you're okay. If you don't have those three professions, you're really in trouble. But if you have those, that's enough. You don't have to tailor it more than that, and you're not going to be able to. So it's important, as you look at what's possible in places like the United States, we have to look at the difference in the geography and the demography. If you look at what the illnesses are in the Southwest and New Mexico, where I've spent a little bit of time, if you look at that in New England, and it's two completely different populations. And again, which of the professions is going to serve that best, and which combinations of those professions will serve that group best? Okay, we can alter the cultural hierarchical environment to meet these goals. That is, to me, one of the most difficult things that you're going to have to deal with. There is a history of the hierarchy of the professions, and they can say that they are going to get by that, but it is not as easy to get by that as you might think. How many people here remember Alma Ata? They're not all as old as me, but Alma Ata was an attempt in about 1978 to put together the health leadership around the world and to come up with a proposal which they called Health for All by the year 2000. That meant that health was not described as simply the absence of disease. It was, in fact, the most positive aspects of mental, physical, and environmental health. Well, when they finished putting this out and everybody got on and signed on, they figured out they didn't know how to get there. And so the question was, if they didn't know how to get there, what should they do? So the Rockefeller Foundation said, we'll put together, and so the next year they put together another group to put some precision to that. But they also came to the position that that was still going to be extremely difficult. And then there was another undercurrent in there, and that was health is too important to be left to the doctors. That was literally said. And so what happened was, in lots of places where the doctors were culturally dominant, they basically didn't play. The result of all of this is that Alma Ata failed. It was a very high-flying, wonderful thing to talk about, but it didn't work. And as you're going forward, keep in mind that there are subtexts in what's going on here, particularly in the interactions between the professions, and think about how that might be worked out. Another assumption, we can bridge the gaps between professions and between theory, the academic, and the practice, and that, in fact, is one of the key features of your discussion today. I think that that will turn out to be, again, I will come back with some thoughts on that a bit later, but I think that is something else that can be achieved. One strategy for turning these assumptions into reality is through interprofessional education. Okay? That I point out, and you pointed out as well, that this is only one strategy. There are going to be other ways to get to what you're trying to do, and it's important to not compete with each other and let the best idea win, and not get so committed to something that you then make it possible to have only that go forward and not something which would be better. And I'm going to come back to that at the very end. Okay, so I now have a few questions that are going to help me answer my assistant's question. First, how many professions define IPE? Is there an ideal number? If you have to put together more than two at a time, what's going to happen? I'll never forget, I was sitting out at Brandeis when the dean of the Harvard Medical School called me down, and he said, I have a great idea. I said, what's that? He said, I'm going to combine the clinical services, at least educationally and functionally, between the Mass General, the Brigham, the Beth Israel, the Deaconess, and Children's Hospital. What do you think? I looked at him, I said, I don't think you can do it. I said, as a matter of fact, I think you would be hard-pressed to get any two of those to work together. And if you try and do all of them, you're going to get none of them. And after several months of working with consultants and so on, the conclusion was reached that no, those groups could never all simultaneously get together. and the MGH and the Brigham got together to form Partners Healthcare, and I will come back to that. So if you're going to increase the complexity, how are you going to deal with that? Can you define that? Do you have some way of prospectively answering that question? Are there irreplaceable professions? Must you always have at least X or Y? If X is nursing or Y is medicine, do you have to always have at least one of those present? I don't know the answer. I do know that you do not have to have certain, or you cannot have certain things as occurred in Alaska. You need to have the ones that match and fit. But that's another important question here. Who drives the bus? How do you get this thing started? Because one of the key issues here is how to actually get this moving. And so are there irreplaceable professions? I don't know the answer to that, but we're going to see a lot of input from people who have been doing this, and we should be able to get some better sense of what they're doing. What's the minimum number of courses or programs you need to launch? If nursing and medicine get together and they have a new course, can we start? Is that do we have interprofessional education? If it doesn't reach out to the practice sites, do we have effective interprofessional education? Don't know the answer to this again, but I am hoping that by the time you're finished tomorrow afternoon, that you will know the answer to this. What role do academicians and practitioners have in the design and implementation of these programs? If you don't have them involved in the design and the implementation, I think you're going to have a real problem. But I don't know how you will do that because, again, the variation in the relationship of the practicing community, whatever the profession is, to the academic community is sometimes fraught with difficulties. Sometimes it is almost a hostile relationship. On the other hand, if you're going to move forward, and if you're going to do what I think is going to be one of the critical things for you to do in interprofessional education, that is improve the care of patients. If you're going to do that, then it seems to me you have to be able to deal with that issue, because as I will talk about a little bit with partners, if you didn't address that issue, you can end up with real difficulties. All right, so how do you define success? What is a successful interprofessional educational program? I've given you some of the parameters that I think have to be included in that, and they don't have the same answer everywhere, but they have to be asked, and they have to be asked up front. And if they're asked up front, you have to be able to set, I think, goals, and you have to be able to then come up with the metrics to see whether you've met those goals. If you have, then I think you're going to be in good shape. If you haven't, you're going to have a problem. I'm going to give you, because I can't imagine this group is not going to be able to answer it, to define success, I'm going to assume that you have defined success. And now, you're not as sure as I am, huh? I can tell. I then would divide my thinking into going forward with 3 tiers. First, let's take the successful programs, analyze their success, and disseminate the lessons. You have a coordinating committee, I think. Is that correct? I mean, this would seem to me one of the critical issues. This tier of things is what I think the coordinating committee should be wondering about. So how do you do that? How do you get that out to people? And how can you actually maybe have an internal consulting process where the people who are really doing it well and have accomplished it can come in and work with the people who have not yet been able to do it and get it going. The second level is to be able, and this is going to be trickier, find out where there are nascent efforts good enough to be encouraged. Are there places that are trying to do this and they can't quite get there? And it's not quite clear why they can't get there, but it's clear that if they were given a little bit of help, a little bit of an analysis, and a little bit of kind of a SWAT team, and have people come in there, work with them, look at what they need, and see whether you can catalyze their growth to the next phase to get them up to the successful program level. The hardest, of course, is to identify areas that are not ready for prime time and to help set benchmarks for change. I think this is going to be a very large array of people, particularly in developed countries, but also in Alaska or versus New England. I think coming up with that level of analysis and being able to then keep that in front of whoever is coordinating these things for the entire enterprise, and then see whether you can help them benchmark a set of activities that will then bring them into a successful interprofessional education. This is where I start getting sweaty. I can go back now, I think, to Yale. When I was at Yale, we had a nursing school and a medical school. And we had in the medical school, we have physician associate program. In the nursing school, we had a nurse practitioner's program. None of those people worked together. It was impossible to get any kind of cooperative venture going. And so here you had a place with a lot of resources, a lot of opportunity, and nothing happened. I think, having been the chair of the medicine at that point, that the key problem there was the university. The university made it possible for the medical school and for the nursing school to ignore each other. If the university leadership had not permitted that, I think we would not have seen the kind of difficulty that we saw. So that was one. Coming down here, it was an interesting thing to try and get the Institute of Medicine to be accepted as a partner with the National Academy of Sciences. They thought, I don't know what they thought we were doing. Maybe they thought we were running some clinics in town, which would not have been bad, but it wasn't certainly what we were doing. And it required actually taking on, as I remember vividly, the first activity. We were bankrupt, and Frank Press was the president. And I said, Frank, if you want us to do, we have to do something. And he said, okay, I will underwrite you for the next, I'll give you half of what you need, and I'll help you get one project going. What would you like to do? This was 1985. I said, we better address AIDS. So we put together a committee, and when I brought this to Frank, he said, well, you have put together a committee which has David Baltimore is chairing it, and you have Howard Temin, and you have the retroviral people on the committee. That's terrific, and let's go. I said, no, the co-chair is Shelley Wolf, who is a clinician, and the public health aspects of this are going to be as important. And Frank said, no, I'm not going to do that. He said, I think we'll look funny if we try and do that. I said, I think we'll look funny if we don't do that. And he said, okay, I told you I would invest in you. Do it your way. And of course, the AIDS reports that came out of the IOM basically changed the entire discussion and debate. And Frank was very gracious about it. But that required us to earn our stripes. We had to be able to show that we could operate in the same arena and to add value, because we could add another perspective. We could add an additional discipline to the discussion, which they did not even know how to think about. And it turned out that that was one of the critical parts of what we were trying to do. Okay, let's move forward now, kind of fun ones. I get to Brandeis, and there's a wonderful young woman who is a classics scholar. And she came to me and said, I have an idea. I want to work with the chemistry department. I said, what? She said, we've been looking at some of the classic buildings in Rome, and they're still standing. We're building things today that have fallen apart. And I know I can interpret. They've actually written out what the contents of their materials are in Rome, and we should be able to reproduce that concrete, and we should then be able to match it against what we have here. I said, well, if you can get the chemistry people to do that, fine. And they did. And it was fantastic. You began to get people asking questions that went, I mean, talk about across disciplines, classics and chemistry. What was important was two things. One, somebody had a great idea. Invest in the person with a good idea. Never fail. That would, the bad thing is to miss that opportunity. Second, put some resources behind it. If we had not put resources behind it, they couldn't have done it. And third, the leadership should give them the leeway to go ahead and do this. Give them permission to do this. And that worked. Okay, now we go to partners. Now, I think one of the great comments is one of our senior surgeons at the MGH said, when he heard that Partners was formed, he said, "Oh my gosh," he said, "in my house growing up, we used to set our moral compass with three constant enemies. There was the Soviet Union, there was Yale, and there was the Brigham." He said, "All that's left is Yale." But if you want to know how serious the cultural difference was to putting those together, and the cultures there were medicine, nursing, allied health, it was all, everybody. So we had a little exercise. We took the people from the leadership, medicine, nursing, and management at both hospitals, and we sent them off to different places. We said, write a mission statement for Partners. Write out the values which you hold most dearly, and write out a vision for what you think this should look like 3 years from now. Well, they were superimposable. You could not imagine how close. I thought somebody was sitting in on both places. It was that close. And once they saw that, they began to say, well, this is probably not going to be as outrageous as we thought initially. Then you better set some ground rules and have people like George to help enforce them. But if you do that, you can actually move this forward. So I think defining what your missions are and see what the great commonalities you have among the professions is one of the things that I think is critical. Trusted, committed leadership. We would not have been able to do that if we'd not had the chief of surgery at the MGH and the chief of medicine at the Brigham as two of the people on that planning committee, because everybody trusted them and we were able to go forward. Leadership is critical. No or few substitutes. I can tell you that if it turns out that somebody has been said to be the leader of this activity and keeps sending somebody else to represent them, it isn't going to go anywhere. People will know they have the leave not to do it. Okay, permission and resources to proceed. Remember the coin of the realm? Academics, part of something innovative is always fun. You can always sell that. Don't you want to be part of innovative? We could embarrass people into doing something on that ground as long as you gave them permission to try and you gave them the resources. The practitioners, it's important to talk to them instead of having, and this is why I said where do they sit in the design. Of course, they wanted to maintain autonomy to the best they could. And this was whatever the profession was out there. It had been practicing and they wanted to continue to do what they were doing. They wanted to do it better, but they needed to have their needs met, and initially the needs were information systems, finances. We made a funny misjudgment. We said, don't bother these folks with trying to get them involved in research because they will not want to do that. Their economics are tight enough. Please don't do that. That was wrong. Turns out several of them came and said, you know, why would we want to be with the MGH and the Brigham if we didn't want to ask some questions about how to make care better? And so we set up a system which allowed them to be able to participate in the kind of clinical trials. Okay, those are just some of the reflections, and I tried to pull some generic aspects out of it. But now, just to finish up, I have a reality check for you. I am convinced by what I've seen even in the outline of what you're doing, that IPE can be accomplished. I think we have examples of it. Good. I would like to go back now and review what I asked you before. Did you set goals up front? Were those goals met? And how do you know? How did you validate them? What metrics did you use? How universal are those metrics? Can you now begin up front to utilize those metrics in any place that's trying to get started in this arena? And how do we know the IPE products deliver higher quality, more effective care? That is one of the two biggest challenges. If you can't answer that question, eventually this will turn out to be a communitarian activity that will be nice in changing some cultures, but you will not be able to demonstrate that they has really had the impact on patient care that you want it to have. And are there models of care which don't depend on IPE that can accomplish the same goals as well or better? Continually be aware of asking that question. So, staying within my time, I want to thank you. It's wonderful to come back to the IOM. It's great fun to work with folks who I really love and admire. And I will stop here and wish you well for the next 2 days, and look forward to the report, which will have answered most of my questions. Thank you.
That was fantastic and humbling at the same time, because I think you have asked some of the most compelling questions before this forum, and I think I'm now more glad than ever that we have at least a 3-year time course to struggle. You pinpointed things we have talked about the integration of practice and education, talked about the fact that we really need metrics, and we struggle with that. That will be a focus of much of our work going forward.